Let's begin part 3 of complications of pregnancy in the second trimester regarding PIH and therapeutic management. There are a variety of medications ordered to prevent the patient from developing a seizure. Magnesium sulfate is administered IV as a loading dose of between 4 and 6 grams in 100 mLs. Usually infused over about 20 minutes. This is followed by a maintenance dose of 1 to 2 grams per hour. Bear in mind that giving magnesium sulfate IV will make the patient feel hot or warm, and it may cause some discomfort to the IV site itself. So keep an eye on it and watch for these signs and symptoms. If the blood pressure is extremely high, antihypertensive agents are administered also. Hydralazine is given IV, and then once the blood pressure is stabilized, the patient is transitioned to oral nifedipine or labetalol. The vasodilation effect of hydralazine benefits the mother by reducing the blood pressure and the baby by improving perfusion to the placenta. If mild PIH is diagnosed on an outpatient basis, labetalol is the drug of choice, and this will be started and continued until she comes into labor. If the blood pressure is well controlled, we'll continue to give this even during labor. When administering magnesium sulfate, there are many precautions the nurse must put into place. Initially, the nurse must assess the patient for the baseline data as described in the previous lecture, and then continue to do this every 1 to 2 hours. Reassess to make sure her respiratory rate is at least 12 per minute and that the DTRs are still present. It is okay for the DTRs to be less brisk than prior to initiation of the mag sulfate, but they have to still be present. If the DTRs are absent, the mag drip must be discontinued and calcium gluconate, 10% in 10 mLs, may need to be administered IV at a rate of 1 ml per minute as an antidote for mag sulfate. Continue to monitor the urine output, remembering that mag sulfate is excreted by the kidney. If the urine output is less than 30 mLs per hour, the risk for mag toxicity increases. The magnesium level is monitored as ordered, with the desired therapeutic level being between 4 and 8. We usually will get this level 6 to 8 hours after initiation of therapy. Now stop and think. What would you expect the management to be if the level was either above 8 or below 4? If the level was over 8, what should you be concerned about? So always remember those focus questions from our clinical write-ups. What are the important assessments to make? What am I on alert for? What are the potential complications and what will they look like on the patient? And then what will you do if those complications arise? So review your notes on what we've already discussed in terms of the assessment and possible complications related to the therapy. In addition to managing the mother, we need to consider the baby. If the baby is less than 34 weeks gestation, we will administer betamethasone, which is a corticosteroid. It is given to decrease the risk of the baby developing either an intraventricular hemorrhage and or respiratory distress syndrome due to insufficient surfactant production. The most common order you will see is betamethasone, 12 milligrams IM, to be given every 24 hours times 2 doses. We can also give dexamethasone IM Q6 hours. Refer to your textbook for the dosage. If the patient has an active infection like chorioamnionitis, we will not be giving this medication. It's too high risk for the mother and the fetus to develop overwhelming sepsis. When you are caring for the PIH patient, make sure you have all the emergency equipment close at hand in case it is needed. Oxygen, suction, the crash cart, etc. Move the crash cart closer to the patient's room. You will want to notify the neonatal intensive care unit and neonatologist of the potential delivery if this is in the management plan. In the event of a seizure, provide the typical nursing interventions you would do for anyone who has a seizure. Call for help. You do not have to do everything by yourself. Make sure the patient is on her side to prevent aspiration and improve perfusion to the placenta while she's seizing. Provide oxygen at 8 to 10 liters via a face mask. You need to document the type and length of the seizure and be prepared to administer Ativan or Valium IV if mag sulfate is not already infusing or if the mag sulfate is not effective in preventing the seizures. Suction the patient as needed after the seizure and expect your patient to be post-ictal and possibly comatose. Make sure you listen to the fetal heart rate during all this chaos. Once the patient is stabilized, notify the physician if she or he isn't already present. As you can see, the patient with PIH is very complicated and the situation can be volatile. It is hard to predict the progression of this condition, so these patients are considered high risk and are usually assigned as a 1-to-1 acuity level. There is no need to fear these patients, just know what to expect, what is important to assess, what complications can occur, and how will they present to you. Then know what to do in case a complication actually develops. Thank you for listening to the 3 lectures about care and management of the PIH patient.